Today we are going to describe the pharmacological action of adrenoceptor antagonists. By combining with the adrenoceptor, the antagonist reduce the access of natural agonists noradrenaline and adrenaline to the receptor. Therefore, they reduce the effect of sympathetic nerve activity. Most adrenoceptor antagonists are selective for alpha or beta adrenoceptors. Selective side-type antagonists also exist. First, the main group of alpha-adrenoceptor antagonists, phenoxybenzamine, phentolamine, and tolazolone, are non-selective alpha-adrenoceptor antagonists. They block effect of adrenaline on alpha-1 and alpha-2 adrenoceptors at similar concentration, without affecting beta adrenoceptors. By blocking alpha-adrenoceptor mediated vasoconstriction, these drugs cause a fall in blood pressure. However, they cause severe reflex tachycardia that now, because of that, now largely obsolete. Phenoxybenzamine is a non-competitive antagonist at alpha-adrenoceptor. The rest of the antagonists I will mention all are competitive. Phenoxybenzamine is not specific for alpha-adrenoceptor and also antagonizes the action of acetylcholine, histamine, and serotonin. Phentolamine binds reversibly and its action is short-lasting. Phentolamine is suitable aid in the diagnosis of pheochromocytoma. In pheochromocytoma patients, an IV injection of phentolamine produces a dramatic but brief fall in blood pressure to near or below normal. Despite the fact that phentolamine and phenoxybenzamine produce a marked fall in blood pressure, they are not useful in treatment of hypertension because the resultant fall in blood pressure is accompanied by an unacceptable degree of reflex tachycardia. Non-selective alpha-adrenoceptor antagonists block alpha-1 adrenoceptor on the vascular smooth muscle, resulting in vasodilatation. However, they also block presynaptic alpha-2 adrenoceptor on adrenergic nerve terminal, removing the feedback mechanism. The explanation for the excessive reflex tachycardia in response to non-selective alpha blocker like phentolamine is that the normal inhibition of noradrenaline released from cardiac sympathetic nerves that occur during reflex tachycardia is abolished. Noradrenaline no longer can activate alpha-2 adrenoceptor because phentolamine occupies presynaptic alpha-2 adrenoceptor. So we have an excessive release of noradrenaline, which causes severe tachycardia. Prazosin, however, produces much less tachycardia for the same fall in blood pressure because it does not block presynaptic α-adrenoceptor. Prazosin is selective for postsynaptic α-adrenoceptor. And the size of reflex tachycardia can still be limited by the normal feedback inhibition via presynaptic α-adrenoceptor. Selective alpha-1 antagonists like prazosin, doxazosin, trazodone are used in treating hypertension. Interference in normal function of sympathetic action on vascular tone make patients susceptible to postural hypotension. Postural hypertension is a drop in blood pressure upon standing from sitting or lying down. Therefore, you should tell your patient that slowly change their position from sitting to standing, allowing time for hemostatic system to compensate. Euhembine is a naturally occurring alkaloid. Euhembine is selective for alpha-2 receptor. It is a selective alpha-2 antagonist. However, it is not used clinically. Alpha-1 selective antagonist is mainly used for treatment of hypertension. Prazosin was the first alpha-1 selective antagonist. Doxazosin and trazodone have longer half-life, allowing once daily dosing. The alpha-1 adrenoceptor antagonists cause relaxation of the smooth muscle of bladder neck and prostate capsule. Therefore, they are useful in patients with urinary retention associated with benign prostate hypertrophy. Tamsulosin is an alpha-1 a-adrenoceptor antagonist with some selectivity for the bladder. Tamsulosin causes less hypertension than prazosin. Phenoxybenzaimine in conjunction with beta-selective antagonists like propranolol or atenolol are used in treatment of pheochromocytoma. Phenoxybenzaimine protects vascular smooth muscle from high concentration of catecholamine circulating in the blood. It is useful in providing cover during surgery. During surgical removal of such tumor, it is likely that large amount of adrenaline are released. So phenoxybenzaimine is non-competitive, so it easily blocks the alpha-1 adrenoceptor. It also used in for the symptomatic treatment in patient in operable cases. Its irreversible action affords prolonged protection. To avoid excessive tachycardia, it should be combined with an antagonist at beta-adrenoceptors. An unwanted effect of alpha-adrenoceptor antagonist associated with vasodilatation or postural hypotension, as I describe it, skin flushing, tachycardia, especially reflex tachycardia, nasal congestion, and impotence. Now we go to beta-adrenoceptor antagonist. Selective beta-adrenoceptor antagonists reduce the effect of sympathetic nerve activity, which are mediated by beta-adrenoceptors. Propranolol, sotalol, timolol are non-selective between beta-1 and beta-2 adrenoceptor, but they are selective for the beta-adrenoceptor at concentration that these drugs block effect of adrenaline on beta-adrenoceptor has no effect on alpha-adrenoceptor. Atenolol, metoprolol, esmolol are more selective for cardiac beta-1 adrenoceptors. For example, atenolol antagonizes adrenaline on the heart at doses that have little effect on the relaxant action of adrenaline on respiratory tract. Butoxamine is a selective beta-2 adrenoceptor antagonist. It is only used as a research tool. Labetalol and carvedilol are mixed alpha-1 and beta receptor antagonists. Their potency on beta-adrenoceptor is 3 times more than that on alpha-1. Labetalol is used to treat hypertension in pregnancy, for example. Carvedilol is used mainly to treat hypertension and sometimes heart failure. Carvedilol reduces heart rate and causes vasodilatation, therefore decrease cardiac work. Reduction in renin release also is useful in congestive heart failure. However, reduced ventricular force could be dangerous in patients with heart failure. Therefore, always benefit should be evaluated against undesirable effect of beta blocker. What it means is that carvedilol in one patient with heart failure might be useful, while in different situations where reduction in ventricular force is life-threatening, it is contraindicated. Oxpranolol, alpranolol, pindolol are beta-adrenoceptor antagonists with partial agonist activity. In theory, drugs with partial agonist activity offer an advantage because they can maintain a degree of beta 1 activation, avoiding heart failure, while at the same time blunting the cardiac response to increase sympathetic activity or the circulating adrenaline. This figure shows heart rate recording in a spectator watching a live football match. Before and after a single oral dose of oxperonolol. As you can see, in the first half time, the heart rate is roughly 120 beats per minute, and from time to time it shoots up. However, after receiving oxperonolol, the heart rate subsides down to normal level and perfectly remove unnecessary tachycardia. I'm going to explain clinical use of beta-adrenoceptor antagonists. Propranolol was the first beta-adrenoceptor antagonist that was designed for treatment of angina. Angina is due to myocardial ischemia, which occurs when the work of the heart muscle increases and the supply of oxygenated blood is inadequate. Propranolol and atenolol lower the heart rate by occupying cardiac beta-adrenoceptors. This prolongs diastole and reduces myocardial oxygen demand, thereby increasing the exercise tolerance in the patient with angina. Beta antagonists can be used to lower blood pressure in hypertensive patients. The mechanism is complex and involves reduction in cardiac output, reduction of renin release from the juxtaglomerular cell by the kidney, and a central action on vasomotor center, reducing sympathetic activity. Probably all three are involved. Propranolol or atenolol are used in protecting cardiac beta-adrenoceptor from higher circulating concentration of catecholamine prior to or during the surgical removal of pheochromocytoma tumor. Propranolol and atenolol are also effective in correction of certain cardiac arrhythmia, especially those due to digoxin toxicity or thyrotoxicosis. Beta blockers are classified as class 2 drugs in the treatment of arrhythmia. Although beta blocker can undermine heart failure, but paradoxically, some of them, such as carvedilol, being used in low doses to treat cardiac failure. Inhibition of central sympathetic outflow, direct vasodilator effect due to alpha-1 antagonism, and prevention of cardiac hypertrophy are beneficial effect which has to be weighed out against its negative inotropic effect. Carvedilol can reduce cardiac output and it can aggravate heart failure. Eye drop containing an antagonist at beta-adrenoceptor like timolol provide useful control of intraocular pressure in chronic simple glaucoma, probably by reducing the rate of production of aqueous humor. The drug can be absorbed from conjunctival sac so that the unwanted systemic effect may occur, especially bronchoconstriction in asthmatic patients. In compared to pilocarpine, physiostigmine, and ecotiophate eye drops, timolol has no effect on eye accommodation or pupil size. Other clinical use of beta-adrenoceptor antagonists include treatment of thyrotoxicosis. Beta blocker controls tachycardia. Propranolol is used as an adjunct to antithyroid drugs. Anxiety is accompanied by tachycardia and tremor. Low dose of propranolol is useful. Migraine prophylaxis and benign tremor are other clinical applications for beta blocker. Airways resistance in normal subjects is only slightly increased by beta blocker without any consequences. However, in asthmatic patients, beta blocker can cause severe bronchoconstriction. Therefore, they are contraindicated in patients with asthma. Beta blocker shouldn't be used. The risk of precipitating bronchoconstriction is smaller with selective beta-1 blocker like atenolol. Despite this, all beta blocker, including timolol eye drop, is contraindicated in asthmatic patients. Another unwanted effect of beta blocker is aggravation of cardiac failure in patients with a small cardiac reserve. Exception is carvedilol, as I explained, in some cases may be used. Another important hazard of beta blocker is bradycardia. Therefore, in patients with heart block, beta blocker are contraindicated. Diabetic patient under treatment with insulin or oral hypoglycemic drug like glibenclamide are prone to hypoglycemia. Glucose release in response to adrenaline is a safety device that is important to alert the patient. The signs of hypoglycemia include hunger, sweating, tachycardia, tremor, etc. The adrenaline response is often sufficient to raise blood glucose concentration. Glucose release from the liver is controlled by beta-2 receptors. Beta blocker mask the hypoglycemia sign and therefore should be used with caution in diabetic patients. Physical fatigue is probably due to reduced cardiac output and reduced muscle perfusion during exercise. Cold extremities is a common side effect and could be due to loss of beta receptor mediated vasodilatation in the cutaneous vessels. Nightmare mainly occurs with highly lipid-soluble drug such as propranolol, which easily enters the brain. It is not a main problem with atenolol, which is water-soluble and excreted from kidney. This picture summarizes the site of drug action on noradrenergic nerve terminal. We have explained in the last couple of lectures drugs that inhibit noradrenaline synthesis. For example, we mentioned metyrosine, alpha-methyltyrosine, that blocks tyrosine hydroxylase and reduce noradrenaline synthesis. Methyl dopa give rise to false transmitter methylnoradrenaline, which is a potent alpha-2 agonist causing powerful presynaptic inhibitory feedback, sometimes used as an antihypertensive drug. Monoamine oxidase inhibitors and selective uptake 1 inhibitors, as I mentioned, are useful for the treatment of depression. Reserpines cause depletion of noradrenaline vesicle. It is no longer clinically used. Indirectly acting symptomatic drugs like tyramine, amphetamine, and its derivatives, methamphetamine and ecstasy, displace noradrenaline from vesicle, allowing it to escape and leads to hypertension. Indirectly acting symptomatic drugs are a strong CNS stimulant. We mentioned about guanethidine, which blocks noradrenaline release partly by local anesthetic action and is effective in treatment of hypertension. We have described selective alpha and beta receptors, agonists and antagonists, and explained their clinical application and limitation. We have started pharmacology of autonomic nervous system with this question: how do drugs act. Now you should know it. Thank you for your attention and good luck.